who is director in the Clinic for Plastic Reconstructive and Breast Unit in Elbert Klingen. Is that right? So please.
Okay, we start now. Dear colleagues and friends of surgical xenology, I am pleased to be able to present my own views and experience on this topic, especially the difference between a subcutaneous mastectomy compared to a glandectomy. Glandectomy, okay. Every operative xenologist should be able to interpret and understand the radiological diagnostic methods. The surgical goal in the treatment of breast cancer and DCIS is to remove all of the invasive and non-invasive tumor parts completely, R0, during the first operation and with pathological confirmation of free margins. By the German S3 guidelines, every patient should be informed and offered a breast reconstruction in the case of mastectomy. They should be informed about all the different surgical techniques. Unfortunately, the human anatomy is not as easy as a piece of cake, and glandular ducts are much more complicated. Breast cancer starts within the glandular duct. It spreads along with the duct system. This is quite a challenge for breast surgeons, especially in DCIS patients. The blue miracle bridge in German translates to experiencing a big surprise, but we don't want to experience a surprise during the surgical removal of the entire mammary gland. The shape of the bridge symbolizes the mammary gland, and the Cooper ligaments we hang up the mammary glands segmentally to the skin. There are also blood vessels in each Cooper's ligaments. Where is subcutaneous fat between the Cooper ligaments. Subcutaneous fat, Cooper ligaments, the muscle, and the skin. Okay, and this one is the gland. Leaving tissue behind means an elevated risk for our patients. To avoid this, we have to understand the anatomy of the breast. The left ultrasound picture demonstrates the left behind tissue compared to the right side, where no tissue is left behind. The fascia of Scarpa is the anatomical part of focus on while performing a glandectomy. This one is the fascia Scarpa. Here is impossible to see, and here is fascia Scarpa, and this one is too much. As the fascia covers the gland, it is the anatomical structure that guarantees a sufficient removal of the gland. The radiologist referred this patient for further treatment. According to the literature, removing the nipple does not reduce the risk. We performed the residual glandectomy on the patient and carried out of the final reconstruction with a bilateral transplant from the lower abdomen using a deep flap with microsurgical connection in the axilla. This one to the deep flap. The nipple is reconstructed 12 months after successful transplantation using a skate flap or dry 3D tattooing. These are two typical examples of recurrence diseases after an insufficient resection of the gland and without focusing on the fascia of Scarpa. Fascia Scarpa here and with lobulars recidive. Okay. Glandectomy is the complete removal of the mammaria gland using magnifying glasses, with the surgical plan being ventral to the fascia scarpa, with intrapapillary mammary duct resections and removal of the fascia of the pectoralis major muscle. The resection of the gland is performed with bipolar forceps and or a monopolar needle. The energy on the electric instrument must be adapted to the tissue quality. The epidermis remains functional. The breast retractor, what you see, has been developed by myself to minimize the punctual stress to the skin. I am a trained mechanical engineer. The example demonstrates a patient with an extensive CIS quite close to the nipple. By performing the right technique and using the right tools, it is possible to conserve the nipple and receive a free margin status from the pathologist. Therefore, we resected the glandular duct from the nipple using a bipolar forceps. You can see this from the inside on the next slide. The next one. Yes. The intrapapillary mammary ducts are completely reduced with the gland during glandectomy. Yeah? The intramammary ducts, and with one all, is epidermis. Preserving the subcutaneous plexus is quite important in order to avoid a skin flap necrosis, which is here demonstrated by diaphanoscopy early in the morning. This one is possible to see. Keep in mind what the patient wants and agrees to when it comes to a glandectomy is a maximum of removal of the mammary gland. It is your job to do so in the best way we can. Thank you.
Thank you very much, Dr. Marks. Any questions from the audience? So maybe we'll do a discussion at the end of the session. So we'll proceed now with the next topic by Dr. De Lorenzi, who is a Director of Innovation, Development and Organization Unit in Milan. And her topic is prepectoral breast reconstruction.
The pointer?
Oh, yes, of course.
So, good afternoon, dear colleagues, dear chairman, dear president. Thank you for your kind invitation. So, the topic of my presentation is prepectoral reconstruction, and I have no disclosure. Conservative mastectomies are nowadays available, and thanks to screening programs, women awareness on breast cancer, digital mammography with tomosynthesis, and they allow the diagnosis of early-stage breast cancer and even non-palpable lesion. And moreover, high-risk women, healthy women, seeking for risk-reducing surgery are the best candidates for conservative mastectomies. Conservative mastectomy allowed to spare the skin envelope, the subcutaneous tissue, the nipple and areola complex is not disease, but not the gland, as Mark told us before. And the conservative mastectomy allows the surgeon to use the prepectoral space, having really natural reconstruction, implant-based reconstruction with the low morbidity. And how we can use the prepectoral space. So in the last decades, we have seen a lot of papers published in the literature about the prepectoral space in comparison to the retropectoral space. So how we can use the prepectoral space without having higher percentage of capsular contraction. So we know that capsular contraction is based on foreign body reaction. And biomaterials may be the key. Why? Because we know that biomaterials play an important role in modulating the foreign body reaction. And there are several papers, experimental papers, clinical papers, demonstrating that with respect to a naked implant, an implant covered with a matrix with an ADM shows a drastically reduced amount of microfibroblast fibers and therefore it is related to a lower probability of contraction. And furthermore, we know that cellular dermatitis decrease the inflammatory response in capsule formation. And also we know that collagen scaffolds reduce the foreign body reaction. So the idea was more than 10 years ago, the idea was to complete wrap an implant, a silicone implant, with an ADM to allow for an anti-contracture effect to be extended over the entire implant foreign body interface. And what we know now today is that if the ADM is properly implanted, there is a cell migration from living tissues to the ADM. So we can say that the ADM can be revascularized and regenerated into patient tissues. So the first effort to use the prepectoral space was 10 years ago, and the idea was to envelope a synthetic material, the silicone implant, with a regenerative material, the dermatitis, the so-called muscle-sparing technique after mastectomy. And now this technique is the gold standard in implant-based reconstruction in selected patients. And today we can use the prepectoral space using collagen matrices, using synthetic mesh, and using polyurethane coated, foam-coated implant. And I will focus my presentation on collagen matrices and polyurethane implants, the technique we are using at the European Institute of Oncology in Milan. So we started in 2019 using the Braxton. The Braxton is a porcine ADM, is a natural collagen, is 0.6 millimeter in thickness. It has no preservatives, and it is provided as dry. And then we moved from the fat Braxton to the Braxton Fast. It is called the 3D ADM because it is lens shape and it is pre-curved. And the advantages of this matrix is that we can have a faster implant preparation, so we have a reduced surgical time, and then it also has a better adaptability in comparison with the first one, and more size are available, and we have no rips and folds at the implant. But every time we use a matrix in the prepectoral space, our goal is to ensure matrix integration. And we know that there is no integration with the correct application of the matrix. So first, patient selection. So prepectoral reconstruction are not for all patients. And I believe that we have to exclude those patients having mastectomy flaps not sufficiently vascularized to allow ADM integration. So we know that medium-sized breasts, moderate ptosis are the ideal one, and we know that in large breasts, sometimes we have a poor vascularization of the mastectomy flaps. The pinch test at the upper pole or on preoperative digital mammogram, we have to have a sufficient thickness of the subcutaneous tissue. We know that the better blood supply, the better ADM integration. And then we have to avoid the heavy smokers or patients with vascular pathologies. We know that BMI more than 30 is associated with a higher percentage of complication. And then I do recommend at the beginning not to use skin-reducing pattern reconstruction because they have a higher percentage of complication, and as well as irradiated breast, because we know that irradiation damages the vascularization and the viability of the mastectomy flap. And this is my personal algorithm for patient selection. I really believe that preoperative evaluation is really important. So 4 main areas. The first one is the patients. So smoking habitus, comorbidities, chronic therapies may impair the vascularization of the mastectomy flap. Of course, sportive women are those that may benefit of prepectoral reconstruction. And then second area is the breast, so the mammogram, the pinch test, the volume, the ptosis, but even previous scars and previous irradiation, because they could impair the vascularization of the mastectomy flap. And then the tumor, of course, has to be resectable, not infiltrating the skin and the thorax, not inflammatory. And then intraoperative evaluation, which is really important. And I do believe that in case of the MAGE mastectomy flap, we have to change our planning. So we have to go to under the pectoralis major. And I'd like to show this paper is by Rancati. We talked before about preoperative digital mammogram. Rancati divided patients in 3 main groups according to the thickness of the subcutaneous tissue in the upper pole. So those women having more than 2 centimeters of subcutaneous tissue in the upper pole are the best candidates for prepectoral reconstruction. On the opposite, patients having less than 1 centimeter thickness in the upper pole are candidates for retropectoral reconstruction. And then in between, we have to decide patient by patient, so reconstruction is tailored to each patient according to the other variable I showed before. And then this is another paper by Rancati, meaning that large breasts do not always have a subcutaneous tissue, not enough. There are, so once again, we have to check preoperatively the mammogram just to have an idea of the subcutaneous tissue after mastectomy. So in my opinion, an accurate preoperative evaluation is mandatory to have the appropriate indication for the use of the prepectoral space and to have good aesthetic results. And these 2 patients probably are the wrong choice, so they are not fit for the prepectoral reconstruction. So they were very thin, they have not enough fat tissue. We cannot graft this patient, so probably in these patients we have to change the plane and go behind the pectoralis major. And of course, anytime we use a matrix, any kind of matrix, biological matrix, we have to ensure the integration. So some tricks, we do recommend to limit the use of electrocautery. Instead, use cold bladders as scalpel and scissor. And do not use povidone iodine solution because it is cytolytic and cytotoxic, so not in the implant pocket and not on the matrix. And then I have some small tricks. So I usually use multiple stitches between the matrix and the subcutaneous tissue just to ensure the integration of the matrix. I usually separate the axillary pocket, the axillary space from the implant pocket if we do not use a separate incision for the axillary sampling. And I usually refresh wound margins at the end of surgery. And if we want to have some data from the literature, this is the IGBES study. It's the largest multi-center data collection on prepectoral reconstruction with Braxton. And it collected 1,415 procedures with Braxton. It's a retrospective study. The implant loss in this series is 6.5%. Being a retrospective study, it has some bias and maybe some information are lost. In fact, if we look at the literature, the published literature on Braxton-assisted reconstruction, we have to say that the majority of papers are of low evidence. So if we measure the paper against the pyramid of evidence, they are level 4 and 5. So the IGBET study is level 4. And the pyramid is well populated at the base, but there is a low representation of the top. So we have the idea, almost 3 years ago, to collect robust data to support this kind of reconstruction. And we set up this randomized trial to evaluate the effectiveness of prepectoral breast reconstruction with Braxton dermal matrix. And breast cancer patients candidate to direct-to-implant reconstruction were randomized at surgery and divided in 2 arms. Arm A receiving prepectoral Braxton-assisted reconstruction, and Arm B receiving retropectoral reconstruction. So these are the patients on Arm A. We use the flat Braxton, and Arm B subpectoral reconstruction. And we exclude those patients having the sentinel node bias positive or those one not good candidates for direct-to-implant reconstruction because we want to have an homogeneous population of patients. And for the same reason, inclusion criteria were really strict, so no smokers, no vascular comorbidities, BMI less than 30, cap B and C breast, good subcranial layer, no previous breast surgery, and not previous breast irradiation. And the aim of the study, of the trial, were to evaluate in terms, both groups in terms of patients' quality of life and satisfaction, to compare the two techniques in terms of morbidity and complication rate in the short, medium, long-term follow-up, and to compare the two techniques in terms of patients-related outcomes. We used the breast Q questionnaire, we used the brief pain inventory, the DASH questionnaire, and we recorded postoperative complication. Patients were evaluated at baseline, 6 months, 1 year, 2 years. And the enrollment closed last August. We included 29 patients for each arm, and this is the randomization. And preliminary results are really satisfactory. All these patients belong to AMR, preparatory reconstruction. All these patients had unilateral mastectomy and reconstruction with no contralateral surgery on the healthy breast. And we could achieve really natural results with low morbidity. But then in 2020, we started using also the foam-coated polyurethane implants, first described by Roy DeVita in 2018. And these are the numbers at the Institute. So from March 22 to December last year, we enrolled 250 patients. 67 procedures were bilateral reconstruction, so altogether 317 breasts. We enroll an increasing number of patients year by year. The mean age is 50. About 65% of patients had a BMI less than 25. About 80% of patients had no comorbidity, and about 70% of patients were no smokers. So once again, the selection of patients, in my opinion, is really important. And then the majority of breasts had no irradiation. 50 breasts received adjuvant radiotherapy, while 20 breasts were previously irradiated. And in this cohort of patients, total implant failure was 3.5%, and capsular contracture rate, classified as Becker 3 and 4, is 6.8%. Some example: tumor located in the left breast, radial incision for nipple-sparing mastectomy and axillary lymph node, sentinel node. Patients receive a prepectoral reconstruction with a polyurethane implant in the prepectoral space, and right augmentation using incision in the inframammary fold. And this is the 1-year follow-up. Another case, really large breast, but the patient was a healthy patient, young patient, and we use really large implant, polyurethane implant, 605 milliliters. And I do believe that in this case, selected cases, the use of the prepectoral space could be a valid alternative to skin-reducing technique. And these techniques are more sophisticated and associated with a higher percentage of complication. And last, I told you that in this cohort of patients, I've included 20 patients having preoperative radiation. This is the case. So the young woman, she had a local relapse after conservation in the left breast, previous bilateral reshaping, oncoplastic procedure. She didn't want any autologous reconstruction, so since she was young with no comorbidity, no smoker, healthy and fit, we decided for prepectoral reconstruction with the polyurethane implant. Of course, a really select cases. I thank you for your attention.
Thank you, Dr. Lorenzi, for the very documented study. Any questions, please, from the audience? Please.
Thank you very much. Could I please ask you, what is the timing between radiotherapy and the operation, if you have to do preoperative?
Okay, in the cases include. So we have different data. So if we speak about the IBES study, the study with 1,500 procedures with Braxton, in that cohort of patients, there are 200 patients who receive radiotherapy in advance, and the mean average is about 5-6 here, because all patients were the local relapse after conservation. And also in the cohort of patients of polyurethane implant in the preperturbal space, the distance is longer, are years. While in case of postoperative radiotherapy, adjuvant radiotherapy, they usually do radiotherapy not earlier than 2 months, but if the patient has to do chemotherapy, they usually have first chemo and then radiation therapy. Yeah.
So, in the case that you have radiotherapy in the past, and are you going, and probably she had a lobectomy in the past and radiotherapy, and then the patient comes with a recurrence or with a new tumor, are you going to do again prepectoral breast reconstruction?
Yeah.
And if yes, are you going to do it with ADM or with a microthane implant?
Okay, it's a good question. So it's not my first choice. So I do believe that in irradiated breast, the first choice is autologous reconstruction. But literature shows us that there are cases that receive before radiotherapy and they were being reconstructed with Braxton matrix, and the percentage of complication is not so high. The failure rate is about 10%. So we started doing this in really selected cases. So 20 patients out of 250 patients. So it's not my recommendation. I do not recommend to start with these difficult cases, but as soon as you are familiar with the technique, and if the patient has no other unfavorable variable, you can do. Of course, the mastectomy in good hand, you have to be really delicate with tissues, but it's not my recommendation.
What about seroma?
Yeah,
Seroma in ADM and seroma in microthane implant.
Okay, I don't have data about from the institute.
What is your experience?
My experience, if you use a matrix, the percentage of seroma is higher.
Yeah.
But in
how many days in the average you keep the drains in ADM? How many days you keep the drain?
Okay, it's really variable in the literature. I take the implant, the drain in place till the amount of drainage per day is about 30 cc. But if you look at the literature, there are different behaviors. So it is also difficult to compare data from several centers. So in the IBES study, the percentage of seroma is 7%. It's really low, but it's a retrospective study. In our trial, still unpublished study, unpublished data, the percentage is higher, is about 13%. But what I have to say that, so when you have a seroma, you have to do percutaneous puncturing, but in the trial, there are included only 29 patients. We didn't have any infection due to puncturing, percutaneous puncture. Yeah.
And the last question, may I ask, do you think you can control the pocket better with the ADM or with a microthane implant? I mean, where to place the implant and finally will stay.
So the micropolyurethane implant have a Velcro effect. Yeah. So you really can control the position of the implant. Of course, you can control the position of the implant even if you use a matrix, because you are going to stitch the matrix on the pectoralis muscle, and then I usually also stitch in the lateral part. It's so easy. So I do 3 stitches in the upper part, and then I stitch also the lateral part, so the implant cannot rotate.
What about, do you kilt the mesh? I mean, you fix the skin to the upper surface?
Yes, I usually do. Yeah, I usually do. I use vacuum suture, and for 2 reasons. I want to reduce the dead space, and I want to promote the integration between the matrix and the subcutaneous tissue. So I'm not used to do preperturbal reconstruction from the
inframammary.
Yes, because it's really difficult, and I cannot put all these stitches. So I prefer to have the radial incision in the lateral quadrant of the breast.
Okay, thank you very much.
Dr. Mastorakos.
Thanks for a great presentation. We know that the polyurethane coating is classified as macrodextrin. So I wonder how you feel
I'm sorry to say that polyurethane implant are not microtexture because inside the implant is microtexture. So it's similar as, but the foam, so polyurethane is a foam, is not microtexture. So it's not the right classification.
You know, Dimitris, if I can make a comment, I totally agree with you. But you know, if you take out the implant after 6 months, it's just a microtexture surface. There is no micro thing.
No, it's not.
I mean, okay.
So I'm really interested in this discussion because between Italian plastic surgeon, there is a strong, controversial discussion. I'm sure that is not microtection. I had the opportunity to work and to discuss with Fabio Santanelli. Maybe you know him. He's organizing this important congress every year in Rome about BLCL. But 100% is not microtection. So I believe it's a this information is misleading. Of course, I'm really I pay attention to any single patient, and I'm afraid of BLCL. Yeah.
Any other question? Dr. Adonopoulos.
Yeah, thank you very much. Congratulations. I like a lot using polyurethane implants, and I present our experience of 6 years in the morning, and I'm very happy. Do you have any experience on using P-line implants in prefectural position in large breast? And my question is, have you noticed any big difference on using P-lights polyurethane implants compared with normal
Polyurethane. So the standard envelope is the same. The velcro fat is the same. The advantages of Belite that they are 30% less heavy because inside there is borosilicate. So we are using at the institute. I don't have data. I believe that for large breasts, the patients can benefit of this implant because they are not so heavy than the classical polyurethane implant, but they are really much more expensive. Yeah.
So, thank you. So we now proceed with the next speaker, Dr. Han, who is gonna present to us implants reconstruction, what to consider.
So thank you very much, dear chairs, dear colleagues. I want to point out some things that we have to consider when we talk about implant reconstructions. And I like breast implants, but sometimes I really don't. And why, I want to explain to you. So, implants are easy to handle. They cause no further donor trauma. It's a fast and easy standard procedure, and it has no long learning curve. But the material defines its limitation. We heard that so far. And long-term outcome is very unpredictable. Compared to autolog tissue, it is not subject to fat metabolism and the regular patient's aging, because the other side of the patient will change over time. So if we take a look at the FDA approval study, we see that after 7 years of primary reconstruction, 53% of our patients will have some kind of complication or symptoms. And that same happen in patients with aesthetic augmentation. What does that mean? These patients have all received a nipple-sparing mastectomy, and these patients are all BRCA mutation carriers, and they all have a prepectoral smooth implant without any kind of mesh or ADM. I stopped using meshes and ADMs completely. You already mentioned some reasons for that, like seromas, and if we trust the data from the FDA approval study, this is what we see after 2 years, after 3 years, and after 7 years. So what are the risks and events that we have to think about? It's the malpositioning of the implant, especially in anatomic implants. It's the capsular fibrosis, it's the rupture rate. We already talked about seromas, and of course the lymphomas, connective tissue disease, and autoimmune disease. So let's get started. Let's talk about malposition and implant rotation. This is a patient who received, because of aesthetic reason, an anatomical implant. And this is how it looked like after 6 months. And it's very easy to see that these patients have an implant rotation. But these implants are not just rotating, they can also turn upside down. And as I mentioned before, we do a lot of ultrasound diagnostics in our institute. So when you look at the implants, this is an old Allergan implant, McGain actually. You see these two points that are at the surface. This is a water bath ultrasound, and this is in situ, and you can actually see these 2 points, and that will always tell you, if you put the ultrasound probe right between the 2 points, how the implant is still based in your pocket. And this is an implant, a Mentor, and you see the back side, and you can see actually this point on the ultrasound. This is a completely upside down turned implant, and this will happen pretty often. As we already published in 2009, and I was very surprised that in 2017 another group published exactly the same techniques. Let's talk about capsular fibrosis. There are actually not a lot of valid data on the incidence, and subject to revision in the literature is for augmentation 5% in the first 2 years. We know that radiation is a significant risk factor. There are many theories concerning the origin of capsular fibrosis, but actually there is not really valid data on other risk factors. Well, let's ask ourselves, is the prepectoral pocket a risk factor for a capsular fibrosis? Well, in this publication, meta-analysis, they said it has a lower rate than retropectoral. In this publication, it says it has a higher rate. So it's really difficult to trust the literature. So let's continue with the rupture rate of implants. Again, there are not a lot of valid data on the incidence, and this is because this diagnosis is actually confirmed either clinically, per imaging, or surgically. So this is something that you have to consider when you read the publications. And in case of MRI-associated ruptures, only 29% opt for surgery within 1 year in the United States. And this causes a large numbers of unreported cases of implant ruptures. What is known? Well, we know that in primary reconstruction after 8 years, 16% in MRI of the implants are ruptured. And in about 64%, as you can see, the reason is a damaging right when we put the implant in through surgical instrument, or when we suture and have contact with the needle to the surface of the implant. Let's talk about systemic disease in silicone implants. And again, let's look at the data of the FDA approval trial on more than 99,000 patients. And you find this table with an elevated number of systemic disease when you compare patients with implants to patients who have no implants. It's an epidemiological analysis on rheumatoid arthritis, sclerodermie, Sjögren's syndrome, melanomas, and also stillbirth and preterm delivery. But don't forget, these are epidemiological cases, and there is a big bias, and it will not give you the causality, the reason why patients, for example, have a preterm birth, and because those are mostly very thin patients who have a higher rate of these kind of disease, and those are the patients who receive the implants. All right, so those are not prospective data. So let's talk about the lymphoma. You know that it's very important when you have a patient with implant-associated anaplastic large cell lymphoma that you resect the capsula completely. And it's a very rare disease, you know that. But it is important that you get the capsula completely removed. And everybody who removed already or had to deal with these kind of patients, and I already did surgery on 2 of these patients, gets the diagnosis. They both were allergen implants. They find the disease because of a seroma. You have to puncture the seroma and give the complete seroma to the pathologist. Here on ultrasound, you see the thickened capsula of this implant. And this is the MRI of the lady. And what we did, we go into surgery, we open up the incision, and this is actually the capsula of this patient. She had retropectoral implants, and it is very hard to remove the capsula from the pectoralis muscle without causing trauma, and it's even much harder to do it from the other side. But you have to be very precisely, and you have to get this capsula out of this patient. So what you see here, this is actually the implant that caused the lymphoma, and this is the puncture that we did. This is the capsula from the lymphoma. This one had no lymphoma. So let's go to another subject. Mario already told about how important it is to see the fascia of the scarpa fascia when we remove a gland, especially in mutation carriers. So don't leave macroscopically tissue behind. And that is a limiting factor when we talk about breast reconstruction. This is a patient, it's a BRCA mutation carrier. You see we have a craniocaudal pedicle here on this mamilla. You've seen this before. These are the perforators for this flap, and we did a retropectoral with an ADM. And this is the situation after the surgery, and this is actually the gland that we removed. And that what you see here is the fascia of scarpa, which give us the anatomical correlate that we know we removed the gland completely. This is a patient after the surgery, and this is her ultrasound result, and you do not see any tissue left behind. So risk-reducing surgery in BRCA mutation carriers is very important, so don't leave any tissue behind. We actually did a couple of years ago a trial that's still going on where we compared the quality of life and the complications on our patients who received mastectomy with implants, pre and retropectoral, and autolog reconstruction. We had in every arm 70 patients, and these are preliminary unpublished data. It's the quality of life measured with breast-Q, and there is something very interesting that I want to point out, and it gave me a new idea what I have to understand. If you look at a satisfaction of our patients with the breast after 6 months, the patients who received an implant, the satisfaction is reduced, while getting a deep flap or an autolog reconstruction with an FCI is elevated. And I ask myself, how can that be? Well, it's very easy, the answer, because most of these patients had a primary reconstruction, and those are the patients who received a secondary reconstruction or conversion when the patients had an implant first. And it broadened my horizon, and it made very clear that the timeline of these patients, to understand the timeline, is a very important fact when it comes to patient satisfactory. Because in this situation, they still have to deal with breast cancer. they still have to deal with other therapies like radiotherapy and chemotherapy. While in this situation, they are very much focused on a permanent reconstruction of their breast. So we have to understand that breast reconstruction with implants is a subject to change over time, and further surgery will most likely be necessary in most of our cases. So the take-home message is, I mostly use round implants. I don't like complications and I don't like rotations. I use not textured implants because of the lymphoma. I love the prepectoral pocket. I stopped using meshes and ADMs. But anatomical correct preparation of the pocket is, from my experience, really the goal to get a nice shaped breast. And you always have to discuss with your patients a realistic knowledge of the medical device implant. Thank you very much for your attention.
Mr. Hahn, thank you very much for your very nice presentation. Any questions from the audience? Please.
Nice presentation, thank you. I would like to ask if, in the case of the AHL that you showed us, did you put the implant, another implant, at the same operation in the pocket that you had?
I discussed.
Just remove the capsule. Did you do a reconstruction with implant in the same operation?
No, I discussed it with both of my patients, and I didn't suggest to do it. They didn't do it. And you want to make sure that you have really that capsula removed completely.
Thank you.
No, I did not. I did not put another implant in.
Actually, we have also an experience with that. It was a reconstructive patient. She developed lymphoma on the one side. That was the cancer side. She had a prophylactic mastectomy also on the other side. So first we removed totally capsulectomy with, and we did a DF flap on this side. And then the patient requested to the prophylactic mastectomy also to remove the implant, and we did a free pap flap. I mean, to be on the safe side of you. Thank you. One question, you said that you're using round implants, and also you don't use textured implants. So you use smooth implants or nano-textured?
Smooth.
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 What happens to the pocket? I mean, the smooth stays there, or you have...
Well, you have to close the pocket on
pockets.
the side, old-fashioned, like we learned it 20 years ago.
Yeah.
You know,
And you have
before
no problems
ADMs
with
and meshes
bottoming
came
out,
up.
or-
And I learned this because I removed with Mario together the implants once the patient built up the capsular contraction, and to remove, for example, non-resorbable meshes is really hard because you destroy the subcutaneous vessels, and that causes a high risk of a flap necrosis on your skin. So the more conversations, converting surgeries you do, the more you find out that you don't want to use meshes that are not resorbable. We did about 150 ADMs with Braxton. They live next door to us, the company, you know. And I found out that seromas are a problem, and in our experience, they don't integrate too much to the skin. And when you go back and you convert these patients, because you have to, you find out that there's like they kind of resorb also the ADMs. You find little areas still with the ADM, and lots of seroma in there. And well, my experience are different, and I stopped using too much medical devices within one lady.
Thank you very much. Please, Yanis.
How much rippling or flipping of the implant you get at about 6 months?
Rippling is a problem, and you showed what kind of a problem it is. But I don't want to discuss that because we have a next speaker talking about lipofilling. And 2 days before I came here, I had a patient with a rippling. I did an autolog lipofilling, and she was sent to us, and she had actually a titanium mesh, and there was 1 millimeter. So I used my ultrasound. I came from the side, and I put the fat cells between the mesh and the skin very, very slowly, very carefully. I didn't rupture the implant. I used my ultrasound, and I love that when it comes to rippling. But always remember, whenever you do a liposuction on your tummy, your patient has to know that you will not use this tummy again for a deep flap. So this patient has to decide whether she wants to have a lipofilling or a deep flap in the future. This is something that you have to consider. All right?
I think you will get rippling to every patient with a smooth implant just under the skin. There's no way you can escape that. So you need to put then fat grafting to every patient. Also, I don't see why you're going to do a DF flap for a liposuction. You can do it.
You can
No, you understood me wrong. In an area where you did lipo, when you did a lipofilling and you received your cells from the tummy, all right, it's hard to use this area again for a deep flap. You can do it if you'd like to. I
think
don't.
it's very safe to do it. I think it's very safe to do the flap after liposuction. Of course, you reduce the volume of the flap. Okay.
Masanat.
Couple of comments. Sorry. So Yazar Masanat from the UK. Couple of comments. Our plastic surgeons will do a DF flap, but they will do imaging to check that all is okay after liposuction. You've commented about the fascia, and also Mark commented about the fascia. We will not excise the fascia in the UK. Fascia is not part of the breast, and so if it's only fascia, if the tumor is not reaching the fascia, anterior or posterior fascia, we will not excise it. I don't know, it seems to be a common practice in Germany to excise the fascia. I don't know what happens in Italy. I don't know what happens here, but fascia is not breast tissue. It will not get breast cancer. If the tumor is far away from it, you should not have a problem from it, as long as you're in the correct plane. Thank you.
I'm talking about the subcutaneous scapa, fascia of scapa. That's what we were talking about. It's an anatomic correlate to remove the gland. So we're talking about two different.
Yazan, can you repeat the question, please?
So the fascia, the pectoralis fascia will not remove it. The anterior fascia, you don't always find it. It's not present in all planes. You have the anterior lamella, and that's the paper of Alberto from Rancati. So on the anterior lamella, some people are talking about the oncoplastic and the plastic plane. And what they're talking about is, are you just going below that fascia, or just taking the fascia with a bit of the fat of it? So that's something that's difficult to describe. The people that for the anterior part will want to take the fascia argue that with the Cooper's ligaments there is some breast tissue going there. The people that don't take it will say no, there's not much there. So it's.
I like your discussion, and we're talking differently. And you also mentioned that it's hard to find it, right? Viviana finds it always. You find it hard. I find it hard. Mario loses magnifying glasses. His eyes are better than mine.
People believe
anyway,
that does not exist.
And the other colleague mentioned how it is with the rippling. And these are all things that we have to consider when we talk about glandectomy. Thank you very much.
Thank you. So now I want to call the next speaker, Dr. Georgia Spiropoulou, who is a professor in plastic surgery in Thessaloniki, Greece. And is going to talk to us lipofilling.
Dear colleagues, good afternoon, good evening. I would like to thank the organizing committee for inviting me to give this talk. Fat cells have a common origin with cartilage and muscle cells, and they are divided in number until puberty, and after that their number stays the same and it just increases in size, reaching a maximum of 120 micrometers. They are the biggest endocrine organ, and they are inside the stromal vascular fraction, that includes nerves, capillaries, endothelial cells, macrophages, and fibroblasts. The white fatty tissue envelops the internal organs in visceral fat pads and exists also in subcutaneous fat pads. And the brown fatty tissue exists mostly in babies, and its use is in thermogenesis. Fat tissue have several functions, so it's for energy storage, the composition and storage of lipids, insulation and general thermogenic heat, protection around vital structures. It's the biggest secretive organ. It contributes to immunity. It metabolizes sex hormones and regulates hunger and satiety, glucose and cholesterol. What are the advantages of fat tissue transfer? It's biocompatible, it's non-infectious, non-allergenic, it has physical and chemical stability, it remains where we put it after it takes, so it's non-movable, it's long-lasting, it has a low cost, it has abundance, but of course not in thin patients, it provides a natural result, it has a low donor site morbidity, and also we can add that to contouring of the donor site, so we can improve the whole appearance of the body of the patient. Also, apart from improving the volume, it can improve the skin quality because it has adipose-derived stem cells that have the ability to regenerate damaged tissues and organs. What are the disadvantages? The percentage of absorption that is unpredictable. So if we take let's say 1 liter of fat from a patient, after we centrifuge it, 40% of it will remain, so 400 mLs. And sorry, I cannot concentrate. I cannot concentrate. The percentage of absorption is unpredictable. So it's 400 mLs after centrifusion of 1 liter of fat tissue. And after that, 30 to 60% will remain. So we are talking about 100 mLs of fat that we can use to augment the breast, each breast, if we do a bilateral breast augmentation. You understand that this is a very small percentage of increase. And for example, you cannot do a one-stage augmentation as long only if you use the Brava device. We are going to talk about that later. In case of BMI increase, there is a possibility of contour anomalies because the fat cells have memory. So if we take fat cells from the hips and transfer them to a contour anomaly, for example, let's say in a supraorbital defect, and then the patient increases the size, then the fat cells there will increase as if they were at the hips. So this may create a lump, for example, if you put it in a supraorbital area. And also, there is no consensus as to which is the ideal technique of fat transfer. Illouz described the liposuction in 1977, and then Klein described the Tumsen technique that we use nowadays. And Birkholt did the first report of liposuction and fat transfer. But it was Coleman in the 90s who set the exact steps for lipostructure, and he described a reproducible method of breast augmentation or fat transfer. So you can harvest fat from any area there is excess tissue, and we use as anesthesia solution Klein solution, that is 1 liter of normal saline with 100 mLs of 1% lidocaine and 1 ml of 1 to 1000 epinephrine and 10 mLs of sodium bicarbonate. The toxic dose of this solution is 2,450 milligrams. We use the super wet technique, that is, we put 1 ml of infiltrate per 1 ml of aspirate. So the donor area does not affect the graft survival, so we can use any part of the body and we can adjust that if we want to improve the contour accordingly. The Coleman technique consists of performing the liposuction with any method that we want, And then we put them, the fat, into 10 ml syringes, and we put them into a centrifuge, and we spin for 3 minutes at 3,000 rates per minute. After the centrifugation has finished, we remove the serosanguinous fluid and the oil, and you can see that approximately 40% of fat remains. This provides more compound grafts, and it's easier to separate the oil and serosanguinous fluid, and the separation is with great accuracy. However, if you don't have a centrifuge, you can use sedimentation that is time-consuming compared to centrifugation, and it's 15 to 20 minutes, and is less effective in the separation. Or if you want to do a mega transfer, you can do liposuction and washing, but the problem in this case is that the fat is exposed on air, so there's a possibility of contamination, and it's time consuming. And there is a greater possibility of oil cysts. There is a report in PRS in 2004 that there are comparable results of survival with centrifugation by Roerich. And of course, this is subject to whatever the surgeon prefers. We prefer to use the classical methods, Coleman technique. So after the centrifugation is completed, we transfer the fat to smaller syringes, 5 to 2.5 ml, and we transfer from one to the other using a connector. We pass 3 times in order for the fat to ensure easy passage of fat. Or if you have the fat gun, a fat injecting gun, you can use that. The fat injecting gun can have an accurate deposition of fat, and it's a greater control than a freehand fat injection. So we create fans from each hole in several levels, and we put the cannula inside, and then we withdraw and leave 1 ml of fat per 5 centimeters of length of the canal, approximately, just in order for the fat to be able to take, because for a graft to be able to take, it has to be close to a well-vascularized bed. For mega fat volume transfer, Curie has described the Brava system, that is his innovation. It's 2 silicone pumps that are placed on each breast, so this pre-expands the matrix, because he thinks that pre-expansion of the matrix is the reason that the fat graft doesn't take initially sometimes. So he described a transfer of 233 ml per breast with this technique. He uses Brava for 10 hours per day for 4 weeks, and then he puts, as we said, 1 ml per 5 centimeters of cannular retraction, and he performs graft layering in 3 planes: the immediate subdermal, the deeper mastectomy level, and the intermediate subcutaneous plane. And he puts post-operative Brava for 48 to 72 hours. And he described a mean 233 ml of augmentation per breast. The indications of fat transfer are small breasts, tubular breasts, Poland syndrome, a contour anomalies after breast augmentation, a contour anomalies after radiotherapy, reconstruction after a lumpectomy and mastectomy, and nipple reconstruction. It can be used in lumpectomies or mastectomies, in breast augmentation or reconstruction, and can be enriched with PRPs. For if you have a small asymmetry, you can do a breast augmentation, and we did a breast augmentation and increase of 1 size. The final result is after 3 to 4 months, and we have to inform our patient about that. There was an initial skepticism about oncological safety. However, this has not been documented by studies. Actually, the fat transfer was not associated with a higher risk of cancer recurrence in cases of mastectomy and immediate reconstruction. And also, the number of suspicious findings after fat transfer to the breast was similar to the one after mastopexy and breast reduction. Where the fat dies, it is replaced by calcium. So this causes calcifications that if an inexperienced radiologist can mistake for cancer. However, the benign calcifications have a different appearance. They are round, while the suspicious calcifications have a linear setting, usually. And this is something that we have to remember. Also, you can do fat transfer around an implant or a tissue expander to improve the contour anomalies and to soften the skin before the expansion. You can prepare the flaps in case they are very thin at the time of insertion and to enhance vascularity and thickness at the time of change from expander to implant. When we remove the expander and we want to convert to fat, in case there is an extrusion, for example, we have to place the fat immediately after removal of the implant. In case of the autologous tissue reconstruction, you can use it to improve the volume. In case, for example, of latissimus dorsi reconstruction, you can use it to improve the volume of latissimus. You can use it for contour improvement and improvement of the flap upper pole in cases of cartilage removal from the fourth to or third rib after a DIEP. The areas that we are going to transfer fat are the upper pole, the periphery, and the midline, usually. So we can do a total breast reconstruction in case we have a small contralateral breast and big hips. This is the ideal candidate because we will improve the contour of the body and we will create a small breast. However, still we need 3 to 4 sessions. It needs several sessions at 3 to 6 months intervals, and the patient needs to have enough areas to take fat from, so it's not suitable for a thin patient. We can do contour improvement, and we can improve the post-mastectomy pain because sometimes you can see a Tinel sign. So if you inject fat there, you can improve the Tinel sign, especially under the scar. You can treat reconstruction. You can improve tissue, skin thickness, and texture. The complications that you may see are absorption, necrosis, oil cysts, infection, and cellulitis. There's a bigger complication rate in cases of multiple lipotransfer sessions, scarring and contracture, and previous radiotherapy. There are some limitations, of course. The patient compliance, because some patients get tired after 1 or 2 sessions. Also, they don't have sufficient donor sites anymore because, as we said, after taking 1,000 mL, maybe 200 will remain. And of course, sometimes it's not suitable for the fat to take because there is radiotherapy that has decreased the bed vascularity. You can use fat transfer to latissimus dorsi for immediate reconstruction. However, in this case, we put also a small implant. We put fat transfer to increase the volume a little bit and improve the contour of the hips. And in this patient, we used latissimus dorsi, extended latissimus dorsi, so we took the fat under scarpa's fascia as well, and we took injection of fat. However, she still needs other sessions because it's smaller compared to the other side. It's a cup A and the other one is a cup B. There are reports in the literature that there is fat transfer around capsule improves capsule formation around silicone implants. This is both in experimental and clinical studies. And as the previous speaker said, you can use it in rippling to improve the rippling. The factors that affect the graft survival is the technique, the smoking, of course, sympathomimetic drugs, obesity, diabetes, and COPD. And the volume stabilizes after 3 to 4 months. If you, in order to have a 70% take, you have to have a 20-year-old patient that doesn't smoke and is fit and well. This is the only time that you have a 70% take. I don't know if anyone here has a better outcome. So the fat transfer is the next big thing. It can be used for correction of contour anomalies, a total breast reconstruction, latissimus dorsi, and fat transfer. Thank you.
Thank you, Professor Spiropoulou. Very educational talk, very useful for everybody here. Actually, we're running very late, out of time, so maybe just one question and just one comment from each commentator. So if there's any question, please, Dr. Antonopoulos.
Congratulations, thank you very much. Yes, the fat for the patient is the money in the bank. So, yes, I completely agree. Just one question. If you do the direct to implant breast reconstruction, do you prefer to do immediately the fat grafting or you wait?
No, I wait.
The wrinkling-
I would wait. I would wait.
Why?
Just
do,
for
do you avoid or is something wrong with the technique? To do it
no,
immediately?
just my feeling, you know, I want to feel safe and be able to sleep well at night. That's all. I would just want to feel safe and relaxed.
Actually, we don't have a lot of time, so just the commentator to make one comment. So, Dr. Mastorakos.
Thanks for the great presentations. A couple of quick comments, actually. There is literature that betadine doesn't hurt ADM, actually, from Alan Gabriel. We know that our Arcadis paper, that there's 1 cm need of thickness of subcutaneous tissue, but that's not actually a requirement. You can look up the paper from Libyan, who says that if dermis is not evident, you can still use the same technique, provided that you know that you will be needing fat transfer in the future. Another comment is that we don't forget that we can always use a tissue expander in the prepectoral space, and that would create some sort of a mesh and a capsule that you can use in the final reconstruction. I agree with Dr. Spiropoulou in terms of not using fat grafting in the same setting as with a mastectomy because you don't really have a closed space to put the fat in. It's much better to do it in a delayed fashion. As far as the classification of BIA-LCL, it's not mine. It's coming from ISO and doctors such as Dr. Munoz, Dr. Clements, and Dr. Nakadiria. And actually, polyurethane has a larger surface compared to even out-of-the
It has.
protection. We can't forget Dr. Rigotti with all his pioneering work as far as the thickness and especially in the radiated tissue. And one last comment, two last comments. At MD Anderson, when they take out BA-LCL, they immediately replace with implants, no problems and no questions there. And supposedly there's data that lidocaine needs to be lower when you're grafting, when you're harvesting fat from grafting. Thank you very much.
Thank you. So, Dr. Michalopoulos, one comment, please.
Thank you very much for the excellent presentations. Just one comment from the first presentation, that we should all take a message from here that we should have in mind that having a good mastectomy provides a good result for the reconstruction. And it's the first thing that we have to take into account when we're doing mastectomy, liposperm mastectomies and reconstructions. And I don't know what the experience of the other doctors here is, but I think that technologies such as ICG, which was not discussed here, is very important to make sure that we have the proper flaps and we don't have problems with skin necrosis in the future.
Thank you. Mr. Massanat, one comment, please. No comments, so thank you for saving our time.
Thank you.
So we proceed with the next session.
Dr. Kondoulis, for the last session, thank you.